I am going to tell you something today that most doctors will never say out loud in front of their colleagues. There are 5 medical checkups, all of them routinely ordered on adults over the age of 60, that I would refuse to have done on my own body. Not because I am against medicine. I have spent more than 2 decades practicing it. Not because I am some kind of contrarian. I follow guidelines every day in my own clinic. But because, after seeing what happens inside real exam rooms, inside real hospitals, to real patients I personally cared about, I have come to believe that some of the tests we hand out like candy after age 60 cause more harm than the diseases they were designed to catch. And almost no one will ever tell you that to your face. I am Dr. Samuel Hart. Over the next 20 minutes, I am going to walk you through 5 specific tests, name them clearly, explain exactly what happens when an older body gets one of them, and tell you what the published evidence actually shows about the trade-offs. By the end of this video, you will have something that very few patients ever walk into a doctor's office with. The right question. This is the key. The single question that, if you ask it before agreeing to any screening, forces the entire conversation onto solid ground. Stay with me until the end, because the 5th test on this list is the one I see ordered most often, on the highest functioning older adults with the least amount of discussion, and it is the one I personally find most concerning. Before I name the tests, I need you to understand one idea, because without it, none of what I am about to say will make sense. In medicine, we have a quiet phenomenon called the cascade. Here is how it works. A perfectly healthy older adult walks into a clinic for a routine checkup. They feel fine. They have no specific complaint. As part of the standard preventive package, a test gets ordered. The test finds something. The something looks like it might be a problem. So a second test is ordered to take a closer look. The second test finds something slightly different. Now a specialist is involved. The specialist suggests a small procedure just to be safe. The small procedure causes a complication. The complication needs treatment. The treatment causes side effects. 6 months later, the person who walked into that first appointment feeling completely fine is now managing 3 new diagnoses, 2 new medications, and a level of anxiety they never had before. And they are measurably worse off than the day they started. This is not rare. This is not the exception. This is one of the most reliably documented patterns in modern preventive medicine. It is not happening because doctors are careless. It is happening because the system we have built is designed to find things. And once something is found, the system is built to respond to it. The problem is that not every finding in an older body needs a response. In fact, many of them, if left alone, would never have harmed the person at all. There is one more concept you need before we begin. Most of the guidelines that recommend these tests were originally written based on studies of younger adults, and then extended upward to older patients without specific evidence for that older group. The risk-benefit math that makes a test obvious at 50 often looks completely different at 75, and almost no one in the exam room ever pauses to redo that math with you. Let me tell you about a patient I will call Margaret. Margaret was 74, a retired nurse of all things. She had spent her entire career in medicine, knew the system inside and out, took excellent care of her health, and was sharp, independent, and active. She went in for her routine yearly physical, feeling completely well, and walked out with an order for one of the screening tests on my list today. What followed over the next 11 months was a cascade nobody planned and nobody predicted. 3 follow-up scans, 2 specialist consultations, 1 minor outpatient procedure, a complication from the procedure, a new medication for the complication, side effects from the medication. And one evening, getting up from her armchair, dizzy from the new medication, she lost her balance and broke her hip. She eventually recovered from the initial shock, but she never returned fully to the level of independence she had the day she walked into that first physical. The original finding, the one that started the whole cascade, was ultimately deemed clinically insignificant. It was never going to harm her, but the process of investigating it did. Margaret asked me one question during her rehabilitation, and her question is the reason this video exists. I will come back to it at the end. Checkup number 1, the whole body CT scan. Over the last 15 years, the whole-body CT scan has been marketed aggressively to health-conscious adults as the smartest, most thorough preventive tool money can buy. You lie down, the machine slides over you, and in less than 10 minutes you receive a complete image of every organ from your neck to your pelvis. The pitch is appealing. Catch everything early. Know exactly what is happening inside your body. Walk away with peace of mind. Here's the problem nobody puts in the marketing brochure. When you scan an entire body that has lived for 60, 70, or 80 years, you will almost always find something. Not because something is necessarily wrong, but because human bodies accumulate small, harmless changes with age the same way an old house accumulates settling cracks in the walls. Tiny lung nodules that have been present for decades without causing anyone a single problem. Small benign cysts on the liver or kidneys. Minor vertebral changes that are simply the structural footprint of having walked the earth for several decades. These are not signs of disease. They are signs of life lived in. In medicine, we have a name for these. We call them incidentalomas. Findings discovered incidentally on a scan that was looking for something else that were not causing symptoms and were never going to. The problem is what happens after the radiology report comes back with one of those findings on it. Your physician is now legally and professionally obligated to investigate. And the cascade begins. A small lung nodule, even one that looks completely benign, triggers a follow-up scan in 6 months. Then another at 12 months. Then another at 24 months. That is a substantial amount of additional radiation accumulating in a body that, after age 60, repairs radiation-induced DNA damage more slowly than it did at 40. Sometimes the follow-up scans look slightly different from the original. That after age 60, repairs radiation-induced DNA damage more slowly than it did at 40. Sometimes the follow-up scans look slightly different from the original. That triggers a biopsy. Lung biopsies in older adults carry real risks of bleeding and lung collapse. The biopsy almost always comes back benign. But by then, the patient has gone through significant anxiety, real procedural risk, and a measurable radiation load. A study published in JAMA Internal Medicine found that whole-body CT screening led to further diagnostic testing in more than a third of participants. And the overwhelming majority of those findings were ultimately determined to be clinically unimportant. Meanwhile, the downstream testing caused real complications in real people. The single question to ask before agreeing to a whole-body CT scan is simple. Do I have a specific symptom that this scan is intended to investigate? If the answer is no, walk out of the room and think about it. Checkup number 2, routine PSA prostate cancer screening after age 70. This is one of the most quietly controversial topics in modern preventive medicine, and it is one that almost never gets discussed honestly in a 5-minute office visit. The PSA test, prostate-specific antigen, is a simple blood draw that measures a protein produced by the prostate gland. In men under 65 with at least 10 or 15 good years of life expectancy ahead of them, an elevated PSA can be a useful early signal of prostate cancer. After age 70, the picture changes dramatically, and here is why. Prostate cancer in older men, in most cases, is a slow-growing disease. It is often slower than the natural course of life itself. Many men in their 70s and 80s harbor microscopic prostate cancer cells that, if left completely alone, would never cause symptoms, would never affect their daily life, and would never be the thing that takes them out of this world. That if left completely alone, would never cause symptoms, would never affect their daily life, and would never be the thing that takes them out of this world. The cancer is technically present, but it is, in the practical sense, harmless. The problem with screening for it at this age is what happens after the PSA comes back elevated. An elevated PSA triggers a prostate biopsy. A biopsy is not a small procedure. It involves inserting needles through the rectal wall into the prostate gland. And it carries real risks of bleeding, infection, and difficulty urinating, sometimes requiring hospitalization. If the biopsy finds cancer, even slow-growing harmless cancer, the next conversation is about treatment. Surgery, radiation, hormone therapy. Each of those treatments carries serious side effects that meaningfully affect quality of life. Permanent erectile dysfunction, permanent urinary incontinence, fatigue and bone effects from hormone therapy. Fatigue and bone effects from hormone therapy. The United States Preventive Services Task Force specifically recommends against routine PSA screening in men over 70 because the trials show that for men of that age, the harms of detection and treatment significantly outweigh the small chance of meaningful benefit. The cancers being found at that age, in most cases, would never have hurt the patient if left alone. The treatments very often do. And yet PSA tests continue to be ordered routinely in this age group every single day in this country. The single question to ask before agreeing to a PSA test after age 70 is this: if this test finds prostate cancer, would I want to undergo surgery, radiation, or hormone therapy? At my age, knowing the side effects. If the answer is no, the test was never going to change anything except cause harm. Checkup number 3. Carotid artery ultrasound in adults without any symptoms. The carotid arteries are the two large blood vessels in your neck that carry blood to your brain. Over the years, they can develop fatty plaque deposits that, if a piece breaks off, can cause a stroke. So on the surface, scanning them for plaque sounds entirely sensible. Catch the problem before it causes a stroke. The logic is appealing. The evidence does not fully support it. Here is the issue. The procedure used to treat significant carotid narrowing, called carotid endarterectomy, is a surgical operation that opens the artery and removes the plaque. That surgery itself carries a meaningful risk of causing a stroke during or right after the procedure. The reason is straightforward. You are disturbing plaque inside an artery that feeds the brain. Sometimes pieces of that plaque dislodge during the operation and go exactly where they were never supposed to go. In patients with no symptoms at all, multiple large clinical trials have found that for adults over 70, the surgical risk of stroke equals, or in some cases exceeds, the stroke risk of doing nothing and managing the patient with medication, blood pressure control, and lifestyle changes alone. In other words, the test finds something. The something gets operated on. And in a meaningful percentage of cases, the operation causes the very event it was supposed to prevent. The American Heart Association and the United States Preventive Services Task Force are both clear on this. Routine carotid ultrasound in asymptomatic adults is not recommended as a standard practice. The single question to ask before agreeing is this: if this ultrasound finds narrowing in my carotid artery, what is the stroke risk of the surgery compared to the stroke risk of simply optimizing my blood pressure and cholesterol medications instead? You are entitled to both numbers before you decide anything. I want to pause here for a moment. We are halfway through the list. Have you or someone you love ever agreed to one of these tests without really understanding what came next? If yes, type yes in the comments. I read every single one of them. Those answers shape every video I make from here forward. And if this conversation is giving you something useful, tap the like button. That single tap pushes this video toward the next person who needs to hear it. Now let's keep going. The next two are the ones I see ordered most often on the most independent, highest functioning older adults, and the ones I most worry about. Checkup number 4, aggressive cardiac catheterization after a positive routine stress test in someone with no symptoms. I have saved this one for the latter half of the video because I think it carries the highest potential for serious harm of anything on this list, and almost no one in the general public knows that. Here is the scenario that plays out thousands of times a year in this country. An older adult with no chest pain, no shortness of breath during activity, no fainting, no symptoms of any kind, goes in for a routine yearly physical. The doctor, following a standard preventive checklist, orders a cardiac stress test. The patient walks on a treadmill while their heart is monitored. The stress test comes back with an abnormal reading. The next conversation is a referral to a cardiologist. The cardiologist looks at the result and recommends a cardiac catheterization. This is an invasive procedure. A thin catheter is threaded through an artery in the wrist or groin, fed up into the coronary arteries that feed the heart, and dye is injected to image the vessels directly. Catheterization carries real risks, especially in older bodies. Bleeding at the insertion site, arterial injury, kidney damage from the contrast dye, which is a particular danger in older adults with the reduced kidney function that comes naturally with age. A small but real risk of stroke during the procedure from disturbed plaque fragments or tiny air bubbles. Here is the part that almost no one mentions. 2 landmark clinical trials, called the Courage Trial and the Ischemia Trial, both published in the New England Journal of Medicine, examined exactly this question. In patients with stable coronary artery disease and no significant symptoms, did aggressive intervention through catheterization, stenting, or bypass surgery reduce the rate of heart attack or death compared to optimal medical therapy alone? The answer, after years of follow-up on tens of thousands of patients, was no. Medication management did just as well, with far fewer complications. What this means is that an older adult with no cardiac symptoms who has a positive stress test, then a catheterization, then a stent, is taking on all the procedural risks while receiving essentially none of the protective benefit that the same medications would have provided alone. The stress test, by the way, has a notoriously high false positive rate in older adults, especially in older women. A positive result in an asymptomatic patient sets off a cascade of events that the research says may not be necessary and may genuinely cause harm. The single question to ask the cardiologist before agreeing to catheterization is this: do I currently have symptoms? And if I do not, what does the evidence say about outcomes for people like me who are managed with medication alone compared to people who undergo the procedure? The answer should be a real conversation, not a referral slip. Checkup number 5, routine colonoscopy past age 75 or 80. This is the one I see ordered most often on the highest functioning older adults, with the least amount of discussion about whether it still makes sense. And it is the one I personally find most concerning. Let me be very clear. Colonoscopy in adults between 50 and 75 is one of the most evidence-supported preventive procedures in all of modern medicine. It catches colon cancer and precancerous polyps early, and it has saved an enormous number of lives over the past 4 decades. I am not arguing against colonoscopy as a screening tool. I am arguing about when it should stop. The United States Preventive Services Task Force specifically recommends against routine screening colonoscopy in adults over the age of 85, and recommends individualized decision-making, not routine ordering, for adults between 75 and 85. The reason is straightforward. Colonoscopy in an older body is not a trivial procedure. The preparation alone, the bowel cleanse the night before, is physically harsh on older adults and can cause significant dehydration, electrolyte imbalances, and falls. The procedure itself requires sedation, which carries cardiovascular and respiratory risks that scale steeply with age. There is a small but real risk of perforation, bleeding, and hospitalization. Recovery from any complication is markedly slower in older adults than in younger ones. And here's the part most patients are not told. Colon cancer in most cases is a slow-growing disease. The benefit of catching a precancerous polyp in a 60-year-old is enormous because that polyp would have had 20 or 30 years to become invasive cancer. The benefit of catching the same polyp in an 85-year-old, even if it were going to become cancer, is much smaller, because the cancer typically takes 10 to 15 years to develop into something that would actually harm the patient. The procedural risk, on the other hand, is immediate. You are trading a small, immediate risk against a benefit that may not arrive for another decade. For an active 65-year-old, that math still favors the procedure. For an 83-year-old with other medical conditions, the math has flipped and most patients have no idea. Colonoscopies continue to be scheduled routinely on adults well into their 80s, often without anyone in the exam room sitting down and walking the patient through that arithmetic. The single question to ask before agreeing to a colonoscopy past age 75 is this: given my current health, my life expectancy, and the risks of this procedure, will the result of this colonoscopy change my treatment plan in a way that meaningfully extends or improves my life? If the answer is no, or if your doctor cannot give you a confident answer, you are entitled to delay the decision and think it over. When Margaret asked me her question during her rehabilitation, she did not ask, "Why didn't anyone warn me?" She asked something more useful. She said, "If I had only known to ask one question before agreeing to that first test, what should it have been?" I told her then, and I will tell you now, the answer is always the same. The single question is this: if this test finds something, what will we do about it? And is that something worth doing for someone my age in my current state of health? That single question, asked before any screening is agreed to, forces the conversation that the system is not designed to have with you on its own. It makes your doctor think about the cascade before it starts. It puts you in the center of the decision-making process where you belong. And it is the question I want you to walk away from this video with. Tonight, written down somewhere, you will find it the next time you sit in an exam room. Let me bring this all together. 5 medical checkups that I would refuse to have done on my own body without a serious evidence-based conversation first. The whole body CT scan, which almost always finds incidentalomas that trigger cascades of investigation for findings that were never going to harm you, while delivering accumulated radiation to a body that repairs it slower with every passing year. Routine PSA prostate cancer screening past age 70, which detects cancers that in most cases would never have caused harm, while the treatments that follow detection meaningfully damage quality of life. Carotid artery ultrasound in asymptomatic patients, where the surgery triggered by an abnormal finding can carry a stroke risk that equals or exceeds the stroke risk of doing nothing and optimizing medication instead. Aggressive cardiac catheterization following a positive stress test in someone with no symptoms, where the landmark trials show medical therapy achieves the same outcomes without the procedural risks. And routine colonoscopy past age 75 or 80, where the benefit to risk math has quietly flipped against the patient, and most patients have no idea. I want to say something clearly and directly because I do not want this video to be misunderstood. Preventive medicine saves lives. Blood pressure management, diabetes control, annual medication reviews, hearing checks, vision checks, vaccinations, basic blood work, all of these are valuable, well-supported, and worth doing. I am not telling you to avoid your doctor. I am telling you to walk into your doctor's office prepared. Write the question down, bring it with you, ask it every time. If this test finds something, what will we do about it? And is it worth doing for someone my age and in my current health? Your doctor will either have a clear, confident answer that satisfies you, in which case proceed with confidence. Or they will not have a clear answer, and that itself tells you something important about whether the test belongs on the plan in the first place. If this video gave you something you needed today, please share it with someone you love. Someone who is about to walk into an annual physical and agree to whatever shows up on the order form, the way most older adults do. The most important thing you can do for their health today might be handing them the single question that changes everything. Subscribe to this channel for more honest, plain language conversations about the medicine that actually affects the way you live after the age of 60. Next time, I am going to walk you through the 5 medications most commonly prescribed to older adults that, in my experience, cause more harm than benefit, and what to ask your doctor before you fill another refill. Everything I have shared with you today is general medical information drawn from published research and clinical guidelines. It is not personal medical advice for your specific situation. Every patient is different, and there are individual cases where each of these tests is genuinely appropriate. The right next step is always to bring this information into a real conversation with your own physician. I am Dr. Samuel Hart. Ask the question. Every time, I will see you in the next video.